We now move on to the panel discussion. I invite the panelists on stage. Dr. Pravilika, she's Dr. Thiru's fellow, and she's been instrumental in organizing a lot of the things in this conference, and she's worked very hard for this conference. Dr. Chandrakumar is the pediatric intensivist at Child Trust Hospital. Neonatologist, I'm very sorry. Neonatologist at Child Trust Hospital, and he's trained from the prestigious AIMS Institute. I don't think Dr. Balakrishnan is here with us. So, Dr. Karthik is joining us from, no, the other Dr. Balakrishnan. Okay, I think we can begin the panel.
So we'll just have a quick insight into our study that's all set for publication. It's about coblation supraglotoplasty, a promising solution for symptomatic and syndromic laryngomalacia children. Our study was a retrospective study. It had 61 patients. It was a 10-year study. And from the analysis, the mean age was 5 months, and male were more common, and the most common comorbidity was the GERD. And the common clinical presentation was chest retractions, followed by respiratory distress and feeding problems. The commonest type that we saw was type 2. The technique was coblation, that initially we were using cold steel, then laser, and then we moved to coblation. We saw complete improvement in 55 of our patients, and in the remaining 6 patients, 1 required revision surgery because there was excess scar tissue on one side and which required a revision surgery, and 5 patients only had partial improvement because of a coexisting syndrome. This is a classical type 2 laryngomalacia. I'd like to ask Dr. Bilagi, how do you do supraglotoplasty with child intubated, or do you intubate all the patients? Okay, and how long do you keep your children intubated for, sir?
As I said, I'm a lone practitioner. I get my patient from neonatologist, and they go back to the neonatal center for further management with the tube inside.
Okay.
At the moment he gains some muscle power and all, we pull the tube out.
Okay.
Keep for a day, and then they go home.
Okay. Dr. Karthik, are you with us?
Yeah, I'm here.
How long did you intubate your post-surgical patients, sir? I mean, there are studies that say that 3 days of intubation would be ideal for the epiglottic pull-up. How long do you like to keep a child intubated?
I usually do my best to intubate them at the end of the case, to extubate at the end of the case before they wake up, if we intubate at all. Ideally, I like to keep them breathing on their own, but if we have to intubate, I like to extubate at the end of the case.
Okay. In that case, have you had any experience on the excess scar tissue formation on one side? Because we had a child which required revision surgery because we hadn't intubated the child, and the child had excess scar tissue on one side, and child required revision surgery. Do you have any experience on that?
You know, I have not had that problem. I do, as I mentioned, I maintain intact mucosa between the different incisions, and I also inject steroid into my incisions, and so I have not seen scar tissue formation be a problem. That said, I think, you know, if I'm doing a revision case or a case where, you know, we do an epiglottopexy, then those kids I might keep them intubated for one night just to try to facilitate separation of the tissues. But I think it has more to do with the incisions than the duration of intubation.
All right. What about the feeds, sir? When do you start feeds orally?
I mean, for an otherwise healthy kid who, you know, who's neurologically normal, I would start feeding once they're awake. You know, I guess if you apply topical anesthetic, then, you know, it might take an hour or two to wear off. But after that, I think they can start feeding.
All right. To Chandrakumar, sir, what are the challenges that you face when a child comes to you intubated or it's not intubated? What are your challenges, sir?
So it depends whether, you know, before the procedure how well baby was doing, right? If the baby was, you know, having significant failure to thrive, feeding difficulties, lot of reflux, baby has had kind of aspirations, the lungs were not good, then we keep them intubated for at least 72 hours as indicated by your team, and then sometimes it may get prolonged if the we need to give some time for the recovery of the lungs and all those factors. Otherwise, if it is a kind of a reasonably kind of pre operative condition was not morbidities were not much, then it is straightforward. After 48 or 72 hours, we extubate the case. But starting oral feeds may take some time. Most often they are on tube feeds for a while before we try oral feeding.
Do you have any peri-extubation protocol that you follow in the NICU?
So, I mean, the protocol which is being followed here is, Dr. Thiru, applies topical steroids around the tube, and then he wants us to keep the baby intubated for 72 hours. We don't use usually systemic steroids before extubation unless we anticipate really, some kind of problem. After discussing with the surgical team, then we may give a couple of doses of steroids, systemic steroids, but usually we don't.
Bilagi sir, do you do FEAST, any smaller study for feeding difficulty children with
No.
laryngomalacia?
My understanding is the obstruction to breathe itself is the primary motor. I take care of that. The child is breastfed next day because all my children are just 1 month, 8 days, that sort of thing. So they
Pravilika.
do well, nothing.
Dr. Kalen is also online.
Kalen sir, do you do FEAST for your children with feeding difficulties before the scopy?
Do I do fees, did you say?
Yes sir.
Uh,
Like a smaller
So-
study do you do?
yeah, we do a flexible endoscopy prior to every supraglottoplasty, and in general, if they have any feeding symptoms, we will tend to do a video fluoroscopic swallow study, but some of them will get a fees, and those that have dysphagia, we will tend to get a repeat instrumental swallowing evaluation after the supraglottoplasty as well, to confirm improvement once they have settled through their postoperative course.
Alright. Do you use any technique other than coblation, laser, and cold steel? Do you have any experience on any other techniques, sir?
I tended to use cold steel, very similar to what Dr. Balakrishnan described, and we were having a sidebar chat about techniques and how much tissue we take, etc. I think we're pretty similar. I tend to take a very small cuff of the cuneiform cartilage in it with my mucosal incision and keep my incisions separate. I haven't been injecting steroid as Karthik has been doing, so maybe I'll think about trying that, but I haven't run into issues with scar tissue postoperatively yet either, and I tend not to intubate our patients except for the most severe ones, some of those coming straight from the ICU. We sometimes have to intubate during the procedure, and then I would often leave them intubated overnight if necessary, or often extubate at the end.
Alright. I think we have one question in the audience. How it is done? So somebody from the audience wants to know how epiglottoplexy is done. Karthik sir?
Sure. There are, I think, several different ways to do it. The way that I have usually done it is just to go transorally, again with the suspension laryngoscope. I will use a coblator to demucosalize the lower half of the lingual surface of the epiglottis, and then, the molecular mucosa there in front of it, and then up onto the tongue base a corresponding amount, and then I'll place 1 or 2 big PDS sutures there to bring the base of the epiglottis forward. When I do that, I try to be careful not to make the sutures traverse the entire epiglottis, because then when you pull them tight, the epiglottis just folds. There are other ways to do it. So Dana Thompson has described an inside to out epiglottopexy, where she takes a Lichtenberger needle driver or other tool and takes a double-ended suture and goes from the endolaryngeal surface of the epiglottis out through the front of the neck and on both sides, and then ties that under the skin, and then Sohit Kanotra just recently described the opposite direction, essentially a percutaneous PEXI, which is also very feasible. And so there's lots of different ways to do it, but I think that you have to consider making a raw surface so that the scar tissue holds the epiglottis eventually, because the suture is only going to last so long.
Dr. Pravilika, I have a question. So if a baby comes with severe laryngomalacia stridor and VFS shows grade 4 GERD with a dilated esophagus, in these kind of scenarios, will you go ahead with supraglottoplasty and fundoplication in the same sitting, or still go for supraglottoplasty, wait to see if the GERD settles down?
Karthik sir?
Sure. So, I'm sorry, if I understood correctly, the question is if the child has severe reflux as well as laryngomalacia, do we do a fundoplication at the same time? Is that correct?
That's my question.
Yeah, we generally have not been doing that. If anything, I think at our institution, our pediatric surgeons have moved more and more away from doing fundoplication because they feel that they often unwrap, and that if it's too tight, you can have trapping of secretions in the esophagus and so on. If the child does not have significant dysphagia that warrants a gastrostomy tube, bad neurologic status or something, we'll usually start with the supraglottoplasty, see how it helps, and then escalate to other things if it does not solve the problem. I'm not sure how Dr. Johnson approaches that.
Very similar. I think in the United States, it's fascinating to me how a lot of community practices are still very high on fundoplication procedures, and I think they probably help a lot of kids who really get a significant benefit from that. But in the academic centers, we tend to see the complications from those procedures, and we tend to have a very overall negative viewpoint of fundoplication procedures. I think it'd be nice in the future at some point if we can work toward a happy medium between those two perspectives. But I'm in a similar situation where our team, those are generally team decisions, and we're leaning away from doing fundoplications very often.
Thank you.
I think we need to wrap up this session because theatre is ready. I just have a quick question for the surgeons. Could you reflect on your revision cases and probably tell us why you've had to go in for a revision in these cases?
Which surgeon?
Any of the surgeons?
I never had to go back for laryngomalacia.
Okay.
Only thing was that there was a granuloma which came in the scar site. I took out. That's all.
Okay. Dr.
That
Kalan or
was
Dr.
great.
Karthik?
They can hear you, ma'am. You can ask.
Dr. Kalan or Dr. Karthik?
Go ahead.
I'll go. Sure. Yeah, one of my partners quotes to his family is a 5% revision rate with supraglottoplasties. I think it's better to underpromise and overdeliver. So I don't think we see a 5% rate quite, but I have seen a few, and I think some of the patients that have required revision surgeries are just more complex. They've got complex neurologic conditions and other genetic diagnoses, and even the second supraglottoplasty wasn't adequate, and they've required tracheostomies and more complex management. But I think I have seen patients where we didn't take enough tissue, and I do feel like I've seen one of my own, and I've seen one that was referred in where initially just a mucosal excision was performed of the supraarytenoid tissue, and persistent stridor was significant, and a revision that included some excision of the cuneiform cartilage was curative in those situations. And then I've seen one that was one of my partner's cases where the aryepiglottic folds just kept scarring shut after the supraglottoplasty, and I was involved in the third case on that patient. And in addition to being very careful about the medical management in a case like that, because I think poor undertreated reflux may have been a contributor, In the third case, we actually performed a suture laterally. If you think about when you're doing a frenuloplasty and you widen a tight frenulum, and then you have this diamond-shaped defect, and you throw a stitch in the middle of that to perform a frenuloplasty, a similar concept is occurring with this excision in the aryglotic folds, and that's what we did endoscopically for this patient. That seemed to be the third time was the charm for them. So they do happen, and you have to be prepared to be creative on revision supraglottoplasty cases.
Thank you. Thank you, panelists.
Thank you.
It was a wonderful discussion.